Hi everyone. In this lecture we will be talking about vestibular and auditory disorders, in other words, dizziness and hearing loss, essentially. And these are certainly some of the most common things that you will see that relate to neurology. Dizziness in some studies is one of the top, I don't remember if it's 5 or 10 reasons for coming into an emergency room. And it is one of the more difficult and frustrating complaints, I think, for physicians, because if you look at causes of dizziness and vertigo, it only seems like there are about 500. And so you need to have a framework for approaching dizziness, or else it's just going to be very frustrating. And so I think what I found most helpful is to try to put dizziness into one of these 4 categories, based on historical features and other clinical findings. So one big category is syncope, which generally describes a lightheaded dizziness where patients pass out, usually on their feet. Vertigo, where there's a definite sensation of movement. The patient feels like they're spinning or the environment is spinning. Neurologic is kind of a broad category, and I'll tell you what I mean by that in just a few minutes. And then psychogenic, which surprisingly makes up about 1 out of 4 patients that come in with the complaint, I am dizzy. Remember that you need 3 things working to have a good sense of equilibrium. You need to have your inner ear vestibular apparatus, semicircular canals, 8th nerve, feeding into the brainstem equally and symmetrically. That's important. We rely on our vision very much for having a good sense of balance. So patients that have something like macular degeneration will often say they feel dizzy on their feet, and that has to do with just, can't tell exactly where the floor is and where things are in space. And then we need proprioception. When you're walking especially, you need to get very precise input to your brain about where your feet are in space. And so patients that have a proprioceptive deficit will, for lack of a better way of describing it, often come in and say, I feel dizzy. What they really mean is they're unsteady on their feet, but those patients will frequently use the word dizzy. Okay, so again, I gave you a long patient vignette at the very first lecture on the neurologic examination. When someone comes in and says, I am dizzy, your job then is to try to fit it into one of these 4 categories. And so ask the patient, what do you mean by dizziness? Could you use another word besides dizzy to describe what you're experiencing? So let's go through the first category, syncope or presyncope. This describes most often a lightheaded sensation that when patients are experiencing this, they often feel cold, clammy, and sweaty, so diaphoretic. And presyncope describes the dizzy feeling. Now, we've all had that. If you just jump out of bed, early in the morning, oftentimes you get a little dizzy feeling. So that's presyncope. Okay, now if you were to pass out, we would call that syncope. Okay, so generally syncope is going to be worse on standing. And so if patients that have dizziness, say it only happens when I'm up on my feet, then that would be one factor that would point towards syncope or presyncope. I need to make some videos available for you. I have them. I just need to link them into Canvas. It was a study in Germany like 60, 70 years ago where they actually induced patients to pass out. And you can see they had the patient squat down and do a vasovagal, then stand up quickly. And so you can watch about 15 patients that passed out, and you would look at these and say, boy, it looks like they're having a seizure because they shake when they pass out. So it's extremely important that you are aware that when someone passes out or you see someone shaking, that does not mean it's a seizure. Could be, okay, but about 1 out of 3 patients shake when they pass out. And this is not epileptic seizure activity coming from the brain. This is just spinal cord mediated movements in the arms and legs. Later on, we'll talk about a movement disorder called myoclonus, and that's kind of how we would classify those movements. That's not important. But the convulsive syncope, just really important because very often, we'll get patients referred and the description is, oh yeah, it was clearly a seizure. The patient was shaking. Okay, but if that patient said, I stood up, I felt very lightheaded and dizzy, and that's the last thing I remember, well, that almost certainly was not a seizure. That was a syncopal event. The patient shook, and we call that convulsive syncope. Okay, that's important because that patient does not need to be on seizure medications, for example. So most common causes, most often this is due to orthostasis. And so these, what we just see time and time again, is older individuals, often that have poorly controlled high blood pressure. Maybe they're on 2 or 3 different medications to control their blood pressure. And then if they're a little dehydrated or they jump out of bed early in the morning, you've got those antihypertensive meds pushing your blood pressure down already. And then you get that drop in blood pressure and patients pass out. Okay, so that is quite common. I would say it is extremely important in anyone that passes out that we always do orthostatic blood pressure testing, or in anyone that complains of dizziness. Okay, so we're looking for a more than 20 systolic, more than 10 diastolic drop in blood pressure when we perform that. Now, one difference between just someone who's orthostatic, maybe they're dehydrated and they're on medications, versus neurologic causes here. Okay, you don't know about this condition yet called multisystem atrophy. We'll talk about that in the Parkinson's lecture. But patients who have Parkinson's disease and autonomic neuropathy from diabetes is that the neurologic causes, when we do our orthostatic blood pressure testing, these patients do not have the rise in pulse that we would see from someone who's just dehydrated. Okay, so that's one way we can distinguish between a primary neurologic cause of orthostasis and your patient who is just dehydrated. A common trigger for neurologic causes of orthostasis is after eating. We call that postprandial hypotension. Okay, especially a big meal, and then someone stands up, they feel lightheaded and passes out. I see that quite a bit in my Parkinson's patients. Other causes of orthostasis, or I should say of syncope, are vasovagal syncope. Probably several people in every medical school class have this. For I think 4 consecutive years, we had a student during our brain dissection labs that experienced this, just kind of the overwhelming sense of, cutting a brain, looking at that. So it's often a strong emotional component that will trigger this. The sight of blood, having your blood drawn, extreme pain. Sometimes a coughing fit can cause this. We call that tussive syncope, but that's really just a type of vasovagal syncope. So all of these cause an increased vagal tone, which causes your pulse rate to go down and your blood pressure to drop. All right, so almost every week, I would say at the VA hospital, whenever they call a code blue, like someone becomes unresponsive, whenever they announce code blue lab, and the whole code blue team goes running down to the lab, I could almost bet that I think in every single one I've ever heard, within 15 seconds, they announce cancel code blue. Okay, why are they canceling code blue? Well, someone is having their blood drawn, they passed out. Okay, they're not having a heart attack or, something else like that. And they wake up pretty quickly. Okay, so if you're working in a lab, you're going to see patients like that all the time. I do procedures like Botox injections, so injecting someone, with needles can be another trigger. And I've had, 2 or 3 patients in the last 20 years or so that have passed out during that procedure. Now, carotid sinus hypersensitivity or carotid sinus syndrome usually occurs in the elderly who have, they're your vasculopath patient, they're hypertensive diabetic patient. And these individuals will often have syncopal events related to head turning. And I really should have included a picture here of the baroreceptor reflex, but they get an exaggerated response from the baroreceptors in the carotid artery that then goes up to the solitary nucleus and then to the dorsal motor nucleus of the vagus, which then causes your blood pressure and pulse to drop. Okay, so if we have someone getting very dizzy, lightheaded, or they're actually passing out due to this, then we think about that the etiology here is at the carotid artery. Now, someone that has syncopal episodes, so again the story is it's not really vertigo, it's a lightheaded feeling, and then they pass out. We always want to think about cardiac causes. If it's not fitting a classic, they're not orthostatic, it's not fitting a typical vasovagal, they didn't turn their neck. And so a cardiac arrhythmia, someone's going in and out of atrial fibrillation or some other abnormal rhythm, can be another cause of syncope. So we may need to do prolonged cardiac monitoring. And now we can send a patient home for weeks to monitor their rhythm, and hopefully we like to catch a few episodes and find out if it relates to an arrhythmia. Okay, so here is an actual patient that I saw maybe 2-3 years ago. It was a 73-year-old man, history of hypertension, complains of dizziness for the last 3 months. His primary care provider ordered a brain scan, an MRI, which revealed a possible, they weren't sure, occlusion of the middle cerebral artery. So he was referred to vascular surgery, and vascular surgery ordered an MR angiogram to get a better look at the middle cerebral artery, and it was inconclusive. The radiologist thought it could just be artifactual, not sure that there's anything real going on there. And so we had what's called a conventional angiogram, and this is where they go in, they inject dye in the groin, which goes up to the brain, and then we can image the blood vessels. There's some risk of doing this. This is not just a benign procedure. There's a small risk of stroke having an angiogram. But anyway, it turned out he had just a congenital vascular anomaly, something that he'd been born with, and so not related to his symptoms. Okay, so he was referred to neurology. And so here's the story. He gets lightheaded on his feet, and it only happened, the dizziness, he only had when he was on his feet. And so we did some orthostatic testing, which revealed a 30-point drop in systolic blood pressure on standing. So I'll highlight again the significance here that when someone feels dizzy, don't go ordering lots of fancy tests right away. Find out, what do you mean by dizziness? And dizziness, in this case, that is, on his feet, we can just do blood pressure testing, and we make the diagnosis without, this is many thousands of dollars here with all these unnecessary tests. All right, now our next big category here for dizziness is vertigo. Vertigo, again, there's a sensation of movement. And we want to divide vertigo into peripheral causes, and by that I mean the peripheral vestibular apparatus, the inner ear, versus central causes, okay, which would be brainstem generally. Now, one big difference between these two is that peripheral vertigo, although you're thinking, okay, I'd rather have something in my inner ear than something in my brain, but yet the vertigo from inner ear pathology is much more intense. And the reason it's much more intense is that there is an incredible mismatch that occurs when you have something going on in your inner ear. So what causes that is that the right ear, let's say that that's the one that is abnormal, If there's some sort of pathology there, it will be communicating to the brain something that is dramatically different than what the left ear is communicating with the brain. All right, and so the brain gets this incredible mismatch, and so that leads to intense vertigo. The vestibular pathways in the brainstem, just like the hearing pathways we talked about, cross back and forth several times. So generally, if something is going on in the brainstem that's causing vertigo, the vertigo is going to be less intense. Now, we also want to look very carefully at the eyes. If we can catch someone, when they're having a vertigo episode, and the nystagmus with a central cause tends to be purely horizontal, back and forth, or purely up and down, vertical, whereas usually with something going on in the inner ear, it tends to be a torsional, twisting nystagmus. And the nystagmus tends to always be in one direction. Interestingly, nystagmus with a central cause, it may be left beating, and then you look later and now it's right beating. So it can change directions, which is unique. Now the next one seems fairly obvious, but this is really, I would say, the key when we're doing our examination, is that someone that has something going on in the inner ear, their exam is going to be normal, other than some nystagmus. Okay, but if you've got something going on in your brainstem, like let's say we have someone with multiple sclerosis that has demyelination in the brainstem, well, they're going to have things like an internuclear ophthalmoplegia, motor and sensory pathways may be involved, cranial nerves may be involved. So we're going to have an abnormal exam in someone that has a central cause of vertigo. Now, the next one can be difficult to assess, but if someone's having vertigo, we'll ask them to fixate on something. And in a central cause, the nystagmus is not inhibited with fixation, whereas in peripheral vertigo, there's some ability to suppress the nystagmus by fixating on an object. Typically, to appreciate that, there are these special glasses that ophthalmology has that we can magnify the eyes and better appreciate the suppression of nystagmus with fixation. And this last one really only applies to the most common causes of vertigo, which is called benign paroxysmal positional vertigo. And in just a little bit, I will talk about the difference here. Let me explain that here once we get to that condition. All right, so BPPV. This is the single most common cause of vertigo. And so the mechanism here is that you have these dislodged otoconia here, usually from the utricle, can be from the saccule. And just because of gravity, these tend to go down into the posterior semicircular canal. And the effect of that is that, these otoconia here in the utricle and saccule, these are meant to sense things like the feeling of going down in an elevator or accelerating quickly in a car. Okay, those calcium crystals do not belong down here in the posterior semicircular canal. And so now what happens, usually triggered by head movement that activates the posterior semicircular canal, is that one ear is telling the brain something very different than the other ear, and that creates a sensation of vertigo. Now, I think most medical students tend to come away with the impression that if vertigo is triggered by head movement, it has to be benign positional vertigo. But really, if you have anything going on in your inner ear, moving your head around is going to worsen the vertigo. So that actually is not our most helpful thing that tells us it's benign positional vertigo. What's most helpful is that the episodes of vertigo are very intense and last for seconds. So it's the duration of the vertigo, which usually is our more specific feature. The vertigo is very intense, and if you've got vertigo, you're going to feel nauseated. Some patients may actually throw up. So I do like to ask patients about, is it triggered by head movement? And so it can be triggered by rolling over in bed. That would be kind of a classic situation. Sometimes sitting up with your head in a certain position can cause that brief vertigo. Okay, so don't confuse that with orthostasis. Remember, there it's sitting, standing up, and you feel lightheaded and dizzy. Now, I used to go into a big, long description to explain the nystagmus, which now I've decided I'm just going to put it as an addendum at the end of the handout. If you're really dying to know why the eyes do this, I just think boards are never going to ask you this. But I think you should know what the nystagmus looks like. And just as a simplistic way of understanding this, maybe pause the video and go walk to a mirror, and I want you to tilt your head back and to your right shoulder while you're fixating on the mirror. Okay, so fixate on the mirror and appreciate what your eyes are doing when you tilt your head back and to the right shoulder. All right, so what you should have appreciated is that the eyes rotate down to the left when you tilt your head back to your right shoulder. And that is actually the posterior semicircular canal that is doing that. So what happens here with these otoconia down here is that they are always activating the posterior semicircular canal. And what that means is your eyes always are wanting to be, let's say we've got a right benign positional vertigo, your eyes always want to go down into the left. Now what happens is the brain doesn't like that, and so the frontal eye fields, the saccadic gaze center, correctively tries to overcome that. And so that leads to this upbeat torsional nystagmus that we see in benign positional vertigo. So it's an upbeat torsional nystagmus, a corrective nystagmus really, which goes towards the involved ear. So if you've got a right benign positional vertigo and you are able to observe the nystagmus, the eyes will be upbeat torsional and to the right. So the bedside test that we do for benign positional vertigo is called the Dix-Hallpike maneuver. And so we turn the patient's head, we lay them back with their head ideally over the edge of the bed a little bit. Okay, this is obviously going to depend a little bit on the age of your patient and the health of your patient, and if they have neck pathology. Okay, and that is usually going to bring on an attack of vertigo. So again, upbeat, torsional, towards the involved ear. So having nystagmus when you do this maneuver does not confirm that the patient has benign positional vertigo, because any inner ear problem could cause vertigo when you lie down or move your head quickly. What is really most helpful is to do the test a second and a third time. So we have to, and this is miserable for the patients, you have to apologize and say, I'm really sorry, but we need to do this again. And what happens is this response fatigues. And by the second or third time, the patient will say, yeah, I didn't feel any vertigo at all. Okay, and that is because every time you lie down, if you've got those otoconia there, they get flushed out to some degree. Okay, so this is what we mean by a fatiguing response, and you would only see that with benign positional vertigo. That's very helpful. Okay, so again, the otoconia and the posterior semicircular canal, which causes the overactive, upbeat torsional nystagmus with the fast phase towards the involved ear. And you don't need to really spend any time with this, although a medical student did a great job showing you how it all works. But what we can do then for these patients, it's called a modified epley maneuver, where we turn the head, we rotate it in different places, and what we're trying to do is to get those otoconia to flush out permanently from the posterior semicircular canal. Okay, one thing that's very important when we do this, the patient cannot lie flat that evening. They need to sit up in a chair, because if they lie flat, the otoconia are just going to settle back in. So this is actually quite successful treatment for patients with benign positional vertigo. Now, another cause of vertigo that is common The big term is an acute vestibulopathy. Okay, and so boards will often use either a vestibular neuronitis or a labyrinthitis to describe this condition. And so this is associated with an upper respiratory infection. So it's felt to be idiopathic inflammation or perhaps an infection that involves the inner ear. And the vertigo is very intense, just like benign positional vertigo, but it's continuous. And generally it lasts for several days. So these patients come into the emergency room, and often neurology is consulted. So we need to do a very careful examination, right? But if this really is just a problem in the inner ear, the only thing that should be abnormal is you'll see some nystagmus. Okay, and if you've got vertigo, you're going to be unsteady on your feet. Okay, but they don't have any other problems because it's not an issue with the brain or with the brainstem. Now, if there's hearing loss along with the vertigo, we use the term labyrinthitis. So in general, we do have a kind of a low threshold, I would say, for doing an MRI in these patients. But certainly, if they've got any focal weakness or any other focal complaints, we'll just do an MRI scan. But it should be normal if this is what we're dealing with. And we can give a course of steroids and medications that reduce nausea to help the patients through this episode. Now, one test at the bedside that you can do in patients with an acute vestibulopathy is the head thrust test. And so what we can do, again, assuming we don't have any neck pathology here, but we'll give the patient a quick head turn to the right. And remember, patients should be able to fixate. Okay, and that's because when you turn your head to the right, remember how this feeds in through the vestibular nuclei here to the opposite PPRF6 nerve complex, okay, which goes to the left eye, and via the MLF to the medial rectus of the right eye. Okay, so again, pretend you're looking up at the patient's face. Here's the nose, here's the right eye, here's the left eye. So moving your head to the right will make your eyes go to the left. Here we're moving the patient's head to the right, the eyes are going to the left. So that's normal. Okay, this is a normal vestibulo-ocular reflex. Okay, but here in this patient who has a right ear vestibulopathy, we've got some problem here with the inner ear and the output via the eighth nerve. And so now when we turn the patient's head to the right, the eyes they can't, maintain fixation. And so they actually need the frontal eye fields up here in the brain to cause a corrective saccade, so they don't stay looking at the target. The eyes go in this direction, and then you'll see a quick corrective saccade so that they can maintain fixation. So if you see something like this, it means there's a problem with the right inner ear in this patient. So head thrust test, just a helpful bedside test in patients that are having vertigo. All right, now another cause, something that happens in both inner ears, is called a chronic bilateral vestibulopathy. Now this does tend to be less intense, and the reason it's less intense is just because you don't have that dramatic mismatch between the right and the left side. And so when we have bilateral dysfunction, what patients will often describe with that is called oscillopsia. And oscillopsia, from the patient's perspective, everything always feels like it's kind of jiggling or bouncing up and down in the environment. And probably the most common one of the most common causes of this is actually iatrogenic, meaning we did it to the patient, or a side effect of treatment. And so a class of medications here, antibiotics that are in the aminoglycoside category, probably gentamicin is the one that is most often used. Usually the story is this is a really sick patient. They're septic, they're in the ICU, they're in a coma. And, we're just kind of doing everything we can just to kind of help the patient survive. And that may involve giving antibiotics in the aminoglycoside category. And so this damages both vestibular and auditory as well. So patients often have some hearing loss as well. And so the patient recovers, and as they come out of their coma, they describe this jiggling of the environment and some hair and some hearing loss. Okay, and so we can observe this type of bouncing nystagmus that correlates with the oscillopsia. Unfortunately, this condition does not have a real good prognosis. So these patients tend to be stuck with some degree of constant vertigo sensation. Now, you already know about another cause of peripheral vertigo involving the eighth nerve, acoustic schwannoma. So I don't need to say much about that. Again, just to remind you that the seventh nerve is right there in the cerebellopontine angle. And so patients may have some lower motor neuron facial weakness in addition to the dizziness. And remember that the cerebellum and the trigeminal nerve are right there as well. So they may develop some ipsilateral ataxia or some facial numbness may be a part of that. And I've told you that if you see it on both sides, that is pathognomonic for type 2 neurofibromatosis. Okay, so here is the cerebellopontine angle right here. And here we can see cranial nerve 7 and 8. This one's maybe a little better. Here's 7, and you can see that the 8th nerve has both the vestibular and the auditory portion there bound together. And here's an MRI scan of a patient with an acoustic schwannoma. Now, an uncommon cause of vertigo, but one you definitely need to know about, is Menieres disease. And this is due to, it's felt to be due to increased endolymphatic pressure. So therefore it involves both vestibular and auditory components. So this is also an episodic feature, sort of like benign positional vertigo, but the attacks last not for seconds, but for minutes, and usually they taper down over hours. So you shouldn't really confuse these with benign positional vertigo. Okay? And remember, your acute vestibulopathy lasts for days. So these patients have vertigo, but during the attacks they also have hearing loss, pressure in the involved ear, and usually kind of a high-pitched ringing sound. That's called tinnitus. Okay, so these often go on over a long period of time, can be difficult to diagnose, but over time, patients tend to have permanent hearing loss. Involvement of both ears is common, and are left with kind of a chronic feeling of some vertigo and gait instability. Okay, so there about 1/3 of patients have bilateral Menieres. So treatment for this, to kind of counteract the increased endolymphatic pressure, we can do a salt restriction and a diuretic called acetazolamide, which I want you to remember because we're going to talk about one other condition in neurology that is treated with acetazolamide. Acetazolamide decreases the production of endolymph. Okay, and so therefore it can be quite helpful in treatment of Menieres disease. Now, central vertigo, again, means something that is involving the central nervous system. So, for example, a stroke or a TIA in the posterior fossa, like lateral medullary syndrome, for example, or a cerebellar stroke. These patients will complain of vertigo, okay, but you are going to have focal findings. Think of all the focal findings that we talked about with lateral medullary syndrome, the facial loss of sensation, Horner syndrome, ataxia. You're never going to find that in patients that have inner ear pathology. Okay, remember that the mismatch is not as dramatic when we've got a central lesion because of all the crossing back and forth of vestibular pathways. So therefore, the vertigo is less intense. Multiple sclerosis is a demyelinating disease, as we've said several times. It usually affects younger people. And so this is quite common that you have some demyelination in the brainstem, and vertigo would be a symptom of that. Can be the initial symptom of MS in 5% of patients. But again, if you're going to have demyelination in the brainstem, you're going to have some other findings, some focal weakness, another cranial nerve that's involved, an internuclear ophthalmoplegia. And this will tell us it's central, not peripheral. Now, patients that have migraine headaches often will have dizziness that can have kind of a vertiginous component, but usually not difficult to diagnose because they've got their classic description of a migraine along with it. Occasionally, patients that have seizures can have some dizziness, vertigo, but again, you look for a history of seizure events, and really anything that involves the posterior fossa. And when we say that, we mean brainstem, cerebellum, dizziness would be a common complaint of that. Okay, so those are our first two big categories of a patient that comes in saying, I am dizzy. Now, neurologic refers to a disturbance usually of either visual or proprioception. And so the patient will use the term, I am dizzy, to try to communicate that to you. So any kind of a proprioceptive deficit. So for example, our patient that has maybe B12 deficiency and is not getting adequate proprioception to the brain, they're going to say, I'm dizzy. Well, that's just because they don't know where their feet are in space. And if you ask them a bit more, the dizziness is going to be just when they're up on their feet. Someone that has any kind of visual loss when they're up on their feet, they're just going to feel a little bit unsteady because they don't have that good sense of where the floor is. So I like to ask patients, are you dizzy in your head or dizzy in your feet? And so these patients will sometimes say, yeah, I feel more dizzy in my feet than in my head. If someone has peripheral neuropathy, that involves the proprioceptive fibers, so you lose some sensation of where things are in space. Posterior column disease, like B12 deficiency, would be the classic example. Visual loss, so again, these all kind of fit in this category. And then just other things. I mean, someone that has any kind of a walking problem, like Parkinson's disease, they're trying to communicate to you that they just don't feel good on their feet. They feel unsteady on their feet. And they'll say, I feel dizzy. And you will find on your examination things that more point towards Parkinson's as the cause for why they don't feel steady on their feet. Very often, gait instability is not due to one thing. It's many different things coming together. So, for example, let's just say we have a patient who has diabetes and maybe some peripheral neuropathy from the diabetes. And maybe they've got some macular degeneration and they're losing vision. And maybe their joints just aren't, they've got hip and knee problems. Well, right away we've got three things that, contribute to having gait instability. So usually when I'm referred someone that is having some gait problems, I find that it's multifactorial. Now, there was a very large study done by neurologists at a dizzy clinic. So these were really specialists in dizziness. And of all patients coming in with a complaint, I am dizzy, 24% was found out to be related to a psychogenic cause, usually chronic hyperventilation syndrome. And the mechanism here is, if, let's just say normally you take 6 or 7 breaths a minute, and if you're just very anxious and you're breathing 9 breaths a minute, okay, you're not going to be aware that you are taking those extra breaths, but those extra breaths blow off carbon dioxide, and that actually has the effect to constrict blood vessels in the brain and create a sensation of dizziness. Okay, so when someone complains of dizziness, we do want to spend some time about any stressors, any anxiety that you're having. If the patient also has numbness and tingling around the mouth or in the fingertips, that also suggests chronic hyperventilation syndrome. They did an interesting study on medical students years ago. where they asked the medical students to slowly overbreathe. Okay, and of course they got dizzy and lightheaded, as you would expect. But what was really interesting is that many of them, I don't remember exactly, 25%, got numb on one side of their body. Okay, and so a hemi-body numbness does not mean we need to have a stroke or something like that. It could be also related to chronic hyperventilation syndrome. So if the patient has episodes of this, we'll take a careful history, we'll talk about anxiety and stressors, but also in the office, I will have patients hyperventilate for 2.5, 3 minutes, something like that. And if that slow hyperventilation in the office, the patient says, oh yeah, that's it, I'm having it right now, then that would really support your diagnosis of psychogenic dizziness. Now let's move on to hearing. And so I did just want to emphasize again that our hearing pathways, just like our vestibular pathways, have multiple crossings back and forth, more than are shown here in this drawing. And so, which does remind me, actually, there was a question on the first exam of a patient who had, I think, a middle cerebral artery stroke, and I asked you what other findings could the patient have. I think it was someone with a Wernicke's, and a fair number chose hearing loss, okay, because, the primary auditory cortex is up here next to Wernicke's area, and so I'll just emphasize again that lesions in the brain or brainstem, with one exception that we'll talk about in the stroke lecture, do not cause hearing loss. Okay, and it's because of the multitude of crossing back and forth. So if you destroy your primary auditory cortex on one side, your other side, still does pretty well to maintain good hearing. So I would just look at again and remind yourself about the Weber and the Vernet testing. So remember, normally there's no lateralization with the Weber testing. Normally air conduction is perceived better than bone conduction. And so usually the biggest giveaway, if you're shown this on a test, is if you have a reversal here. Bone conduction is greater than air conduction. You're dealing with a conductive hearing loss. Okay, so when we do audiogram testing, normally here we sense the threshold for when sound can be observed. And so normally we're kind of in this 10 to 20 decibel range. So this is normal hearing here in this individual. Okay, so when someone can't perceive sound until we get, above 20 decibels, so if someone is in this range, they have mild hearing loss. If we're getting way down into the 80 decibels, then that's obviously quite profound. So one cause of conductive hearing loss is called otosclerosis. This is a hereditary condition, usually starts third, fourth decade, and the cause is temporal bone overgrowth, which causes a fixation of the stapes here. So here's the otosclerosis affecting the stapes here in the oval window. And so we don't have a good transfer of sound into the inner ear. Okay, so we're going to have hearing loss as a feature of otosclerosis, and we can do imaging. For example, remember CT does a good job looking at the bones. We can do a kind of a thin section CT scan here of the inner ear to diagnose this. Other causes of a conductive hearing loss would be, a child that has an ear infection, so acute otitis media, or maybe we've got a lot of earwax or a foreign body, something like that. So we do our hearing test and we see here hearing loss, in this case in the right ear. Tympanic membrane perforation would be something else. So, you want to be good when someone has hearing loss, good with your skills of looking in the ear and being able to appreciate this. And this is such a poor example. I'm just really sorry. This is the best one I could come up with. But this was an actual audiogram here showing you that these symbols are for testing bone conduction, and here for testing air conduction in the right and left ear. So I'd never show you something like this because it just isn't clear, but what we can appreciate here is that we get a flip in the relationship here between air conduction and bone conduction, suggestive, again, of a conductive hearing loss. Cholesteatoma is another cause of conductive hearing loss. These are skin cysts that tend to grow here into the mastoid air cells and extend into the ear. And so it's destructive both to the bone in this area as well as to the ossicles here. Okay, so this is just kind of a picture of it here. Presbycusis is the most common cause of hearing loss, and this is what we see in the elderly. And just kind of overall, hearing loss over the age of 65 is extremely common, and most of the time that will be due to presbycusis. So this is due to degeneration of these hair cells here, and it tends to be more of a high-frequency hearing loss. These patients will also complain of kind of a high-pitched ringing in their ears, kind of along with that. And so what most patients with presbycusis will really complain about is when they go out to eat, that the external noise makes it very difficult for them to engage in a conversation. And so that becomes quite a frustrating experience for them. And so hearing aids, cochlear implants, and a variety of things can be very helpful for these individuals. So if you see an audiogram like this, okay, this would be a more clear demonstration. And so, here we've got hearing in a normal range, but once we get into the higher frequency, so it's a high frequency hearing loss. So if you see an audiogram like this, the diagnosis is going to be presbycusis. So they do fairly well here in the lower hertz, but at the higher frequency, that's where the deficit is obvious. Menieres disease, remember that if someone has Menieres disease, over time they develop hearing loss. Acoustic schwannoma also will produce hearing loss, which we can see quite profound here in the left ear. The conditions we talked about earlier with dizziness, like an acute vestibulopathy. Remember, we use the term labyrinthitis if it affects hearing, or chronic vestibulopathy, like the patient getting gentamicin. Those also would overlap, having both dizziness and hearing loss. One of that is, I think, worthwhile knowing about are patients that suddenly develop hearing loss. It's a sudden sensory neural hearing loss. Now, this can be idiopathic, or we think some of these relate to a virus. We call that a viral cochleitis. And it is kind of interesting, the patient profile who gets this. So it tends to be middle-aged individuals, and it's quite highly associated with having a low fresh vegetable diet. Interesting. So these individuals are treated acutely with high steroids to try to preserve some hearing. Hearing loss in children, especially that have meningitis, is quite common as well. A type of hearing loss that has such a unique feature on audiogram testing are individuals that are exposed to loud noise. I see this quite a bit in veterans that have experienced loud explosions in their military service and complain of hearing loss, ringing in their ears. And so what we see classically in these individuals is a drop in hearing that is kind of in the 3,000 to 4,000 hertz range. So if you see just a sudden drop like this, then this is due to chronic loud noise exposure. Someone that's, I had a patient I saw that was in a rock band. I think it was more just like a home band or something, but he really played drums all the time, complained of hearing loss, and we did an audiogram, and it looked very much like this. Now, I'm not going to talk about this now, because in the stroke lecture, I will explain this in a lot more detail. But there is one stroke that involves the anterior inferior cerebellar artery, and this is the stroke where you get hearing loss. Okay, so I'll explain it in the stroke lecture, but that is important you remember that. Ototoxic substances. In this lecture, I've just mentioned gentamicin in the aminoglycoside category, but there are a number of other medications which have the potential for ototoxicity. So it is important when someone has hearing loss that we look at medications that they're on. And congenital hearing loss is also quite common, but I'm not going to go in and explain that. And just kind of a last slide here, if it's helpful, showing you, here are decibels, and here is the frequency of sound. So notice you've got F, S, the th, th. These are high frequency, right? So someone with just presbycusis, when we're communicating, like in a loud restaurant or something like this, these kinds of sounds in spoken language will be especially difficult for those individuals.